Okay, here we go. So, today we are going to speak about the topic of neoplasia. So, two things we are going to do today. First of all, we are going to initiate neoplasia. We are going to speak about so many stuff in it, but I don't think we will be finishing it. Then we are going to be reviewing CVS as much as possible. So by tomorrow, we will be done 100% by neoplasia and we'll be starting renal. So to start with neoplasia, it's basically like the scientific word of saying cancer. So what is cancer? The idea of cancer is the following. You have ridiculous proliferation of the cell that is not happening correctly. Okay? Okay, so guys, by the way, you have like until the first break, whatever questions you have from cardio, just send them on Telegram so we will sum them up in the same location and then we can review them, okay? So, just you have like this 1 hour until the first break, and until then, get whatever question you got and throw it on Telegram and we will do them together. Okay, speaking about neoplasia. Neoplasia is the following. It's an uncontrolled monoclonal proliferation of the cells. So here we have some vocabulary to get comfortable with. What is monoclonal? What does it mean? Monoclonal means the following. So, if you have the 3 stem cells, okay, they are supposed to give you what? Well, this one is supposed to give you 3 cells, okay, and this one is supposed to give you 3 cells, and this one is supposed to give you 3 cells. So we say that this form of proliferation is polyclonal. Polyclonal, it means that it comes from different stem cells. As you can see, 3 stem cells. If we say that something else happened, what happened? Stem cell number 1 gave 3 cells. Stem cell number 2 gave 3 cells. Stem cell number 3 gave you, let's say, well, I don't know, 200,000 cells. So stem cells number 3 is making so much cells. When you have hyperproliferation of the cells in a really ridiculous number in an irregular fashion due to a mutation inside of the cell, we call that neoplasia. So as you can see, this is the process of neoplasia. And since they are coming from only one cell, all of these cells, we call it monoclonal. So monoclonal, it comes from one stem cells. Polyclonal, it comes from multiple stem cells. So they write in first aid, uncontrolled monoclonal proliferation of the cells. It can be either benign or malignant. So any neoplastic growth has 2 components, parenchyma, which is the neoplastic cells, and supporting stroma, which is non-neoplastic cells, like the blood vessels and connective tissue. Without the blood vessels, your cancer cannot function normally. Cancer cells tend to proliferate a lot. If you proliferate a lot, that requires you to have more energy. So the more energy you will be consuming. So I hope it makes sense. So you need more energy and thus you need more blood vessels. That's why we have formation of a lot of blood vessels. So let's speak a little bit about the cancer, about the story of the cancer. Let me just do this. Okay, starting with the following. We have the following example. First of all, you have normal cells. Normal cells with a basal apical polarity. What does that mean, basal apical polarity? Well, it means that when the cells are organized here, as you can see, guys, they have what? They have these cells and they are located like this. Yeah? And if you take a deeper look at their nuclei, they are at the same level. Yeah? Well, maybe one is up, one is down, but overall they are at the same level. Well, if you take a look at the cancerous cells, they have total loss of the polarity. Each cell is larger than the other with different shapes. Some nuclei are up, some nuclei are down. which means that they lost their polarity. So normally you should have basal to apical polarity, and you can see the cervical example in picture A, which is down here. So picture A, I like this one. So you can see, first of all, notice, I know most of you hate histology, but just hold it for a second. First of all, can someone really smart tell me what this is? This thing here. What is that? No, it's not a granuloma. It's not giant cells. Excellent, it's a blood vessel. You can see the little RBCs inside of it. Yep, it's a blood vessel. Okay, so at this area here, you have this thing. This is basically what? If I enlarge a little bit more, I know this quality is not the best, but bear with me. You can see here a layer that is empty from any cell. This we call the basement membrane, okay? On it, there is formation of some cells. Until here, the cells are normal. But the more they progress, the more they become altered. In shape, I mean. So let's just cervical cancer progression histology. Just want to find a better quality picture for you guys. Okay, yes, this is good, really good. So you can see here the polarity is amazing. Like the cells look normal, everything is good, they have different shape, everything is fine. And then you have progression of the dysplasia until it becomes really bad and invades the cell. This is the overall picture. The histological picture, if we go back here, you need to understand the following. So, which shows normal cells and the spectrum of dysplasia as discussed below. So what is dysplasia? Dysplasia is loss of the uniformity in the cell size and shape, which we called pleomorphism. So loss of tissue orientation, which we said it's like the basal to apical polarity will be like screwed, and the nuclear change, which is due to the increase in nuclear cytoplasmatic ratio. Question will be why there is an increase in the nuclear cytoplasmatic ratio. The reason is that if you are going to make a cancer cells, do you need more nucleic acid material or less? You need more DNA or less DNA, basically. Do you need more DNA? Yeah, you need more, obviously. So if you need more DNA to make much more new cells, where is DNA stored inside of the human cells? In the nucleus. So the nucleus will be much bigger, and this is why you have more in nuclear to cytoplasmatic ratio. It makes sense. It just like if you think about it, it makes totally sense. So there is something called carcinoma in situ. Let me do my drawing because I cannot find a good drawing, so I will do mine. This is the basement membrane. I will make it orange. And then on it you have multiple cells. Okay? Let me just, for the sake of simplicity, make them like this. Let's imagine that we have let's imagine that the cervix only consists of 3 layers, okay? Forget about this one. This is a mistake. Okay, so let's imagine that it composed from 3 layers. Layer 1, 2, 3. So this is 1, this is 2, this is 3. This is basement membrane, okay? And this is subcutaneous tissue, okay? This is the underlining, like the fat, like the okay, so if we say someone has dysplasia, mild dysplasia, we have how many layers affected? Maybe 1. Yeah, that's it. Is it reversible in case of mild? Yep. So if we say it's moderate, how many layers? 2 layers. Severe, is moderate reversible? Yep. Okay. What about severe dysplasia? It's a 3 layers. Is it reversible? Okay. If we speak now, so until here, yes, there is risk of a progression in case of severe. It can like actually become cancer. But if you, for 100% remove the stressor, it can be reversible. But if we have affection of the whole thing, let's say that we have affection of the whole layer 1, the whole layer 2, whole layer 3. The whole thing is affected. We do not call it dysplasia anymore. Keep in mind that the basement membrane is still intact. I did not penetrate him yet. So we call this carcinoma in situ. Okay? Carcinoma in situ. Okay? Or CIN, they like to name it. Carcinoma in situ. So this carcinoma in situ is pretty serious, but it's not penetrating the basement membrane, which means there will be no metastasis. Let's imagine that there was penetration of the basement membrane. Okay? And now this cancer cells has immigrated inside of your tissue. And this moment, when you had the penetration, we change the name from carcinoma in situ into neoplasia. Okay? So, we spoke about mild, moderate, and severe dysplasia. We spoke about carcinoma in situ. And finally, we spoke about like the progression and formation of actual neoplasia with metastasis. What happens next that actually it goes to a blood vessel, and we will speak about like the metastasis into other organ or to lymphatics a little bit later. So here they write carcinoma in situ. It's an irreversible, it's already too late. It's an irreversible severe dysplasia that involves the entire thickness of the epithelium, but does not penetrate the intact basement membrane. The basement membrane is not touched. He is still intact. Okay, so that's like the line stay there. The next one is invasive carcinoma, which I showed you. Cells have invaded the basement membrane using collagenase and hydrolysase. What is that? What is that? These are metalloproteinases. You must know about metalloproteinases. I will speak with you about them in a second. So also there is this cell-to-cell contact are lost by inactivation of E-cadherin. So what are they speaking about? Guys, if this is the basement membrane, and here you have epithelial cells. Let's now imagine that there is only one layer for the sake of making it faster. Let's make the cell color blue. And here we have the following. Okay. Damn it. Okay, so this is in orange, this is the basement membrane. And now, first of all, these two cells are connected to each other using like this binding proteins that bind each two cells to each other, okay? They keep them attached to each other. They adhere them to each other, so we call them cadherin, okay? So cadherin. So you can see here the E-cadherin, they adhere the two cells into each other, okay? They keep them like exactly tight protein. They keep everything tied to each other, attach everything to each other. So that makes sense. Well, what else? You downregulate the cadherin, so there will be spaces between the epithelial cells, yeah? And when the epithelial cells have a space between them, they will move like this, will go like this will go like this. Who will be exposed? Who's that in orange? Yep, the basement membrane will be exposed. And to expose to whom? To metalloproteases. Metalloproteases are these guys. Okay? So these metalloproteases, they come and they are like, wow, what should we do, guys? Well, you can come here and just degrade this basement membrane. How to do that? Well, you know, the basement membrane is made from type 4, you must know this, type 4 collagen, okay? And you guys, metalloproteases, know exactly what you are doing. So please just degrade it. So the metalloproteases comes and degrade the collagen inside of the basement membrane. So the right cells have invaded the basement membrane using collagenases and hydrolases, like metalloproteinases. So the cell-of-cell contact is lost as well due to the inactivation of the E-cadherin. So no E-cadherin, no attachment of cell to cell. No. And then you have metalloproteinases, which destroy the basement membrane, and then metastases occur. Well, already you have an invasive cancer because of this process. Now, you are left with one more step for metastasis, which occur when you have spread to a distant organ, like when you go to the other organ, that we call metastasis. It doesn't matter if you go through the lymph nodes or the lymphatics or the blood. You will know in the future that there is exact tumors that love to go through the lymphatics, and there is exact tumors that like to go through the blood. But for now, just know the general idea. Cancer is a monoclonal proliferation of cells. It can be benign or malignant, and it metastasizes by decreasing the cadherin and upregulating the metalloproteases. Now let's speak about some, I hate this word, nomenclature, which means like the names of the tumors. But the topic here is super easy, but it's about memorization actually. So let's just take a moment to memorize this stuff. Just a sec. Since you guys kept telling me about 2021 first aid, I got it. And yeah, I will be explaining this topic from it for you today. So here we go. It's exactly the same so far. Well, tumor, let's speak about the tumor names. First of all, we have carcinomas. Well, when you hear the word carcinoma, it means it comes from epithelial origin. So, whereas the word sarcoma, it comes from mesenchymal origin. Can you give me an example of a mesenchymal tissue in our body, guys? Any mesenchymal tissue, doesn't matter. Bone is a mesenchymal tissue, excellent. Muscle is a mesenchymal tissue, correct. So, excellent job, guys. And both terms generally imply malignancy. Sarcoma, carcinoma, it means something malignant. It's actual cancer. While benign tumor are usually well differentiated and well demarcated, with low mitotic activity, no metastasis, and no necrosis. For example, like a lipoma, which is like a growth of overgrowth of fat cells. You know, a lipoma, it's not malignant, it's totally benign. It's just like an overgrowth of the cells. It's totally benign. Mostly it will not become malignant, will not lead to any problem. But it's still called a tumor. It has that reputation. So the tumors are usually well differentiated and well demarcated with low mitotic activity, no metastasis, and no necrosis. So, okay, so far so good. It seems fine. They are like just an overgrowth of tissue that should not be there, but they are not going anywhere. They are not having high mitotic activity means the ability to divide, guys. So if you have a low mitotic activity, that means that you are not hyperdividing, you are not invading anybody, you are not consuming the body energy as well. While malignant tumors, cancers may show poor differentiation, erratic growth, they grow all over the place, they don't really care where they grow, they just want to grow. They lead to local invasion and they can even metastasize. Metastasize means the movement of the tumor from one organ to other organ. And here we can see decreased apoptosis. Remember when we spoke about apoptosis, guys? It's the programmed cell death. We said that apoptosis is really important for us. One of the many reasons was because it helped us prevent autoimmunity. That's one. Two, prevent cancers. That's two. Three, in embryology, it helped remove from us tissue that should not be there, like the whips between our fingers. So, okay. So terms for a non-neoplastic malformation include hamartoma. So guys, you need to be really focused here. Some non-tumorous overgrowth One of them is called hamartoma and the other one is called a corystoma. They love to ask about this. So just for this next 2 seconds, just focus with me, then you can take a nap. So it includes the following. Hamartoma is a disorganized overgrowth of tissue in their native location. For example, if you have an intestinal cells that are overgrowing in the same location, like in the intestine still, we call that a what? We call that a hamartoma because they are located in the same place where epithelial cells of the GI is located. So if you have an overgrowth of the same cell, the same tissue at its original location, it seems like you want to say hyperplasia, but it's a little bit more excessive than hyperplasia, so we call it a hamartoma. Okay? So, for example, one example on this is something that is called Boettiger's polyps. I will teach you in the future in GIT what these are. Just for the sake of fun, this was the disease that I told you, please do not mistake it with Weber-Randy syndrome, okay? Because they have, these guys have the maculas, while the Weber-Randy had the telangiectasias, okay? The one, yes, it has this brown maculas on the lips, exactly. So, keep in mind that these patients have all of these in their intestine. These are polyps, okay? So now we are going to speak about, no, but esophagus is a metaplasia. That's different a little bit. So if we speak about corystoma, it's a totally normal tissue. It's normal, like in characteristic, does not have increase in nuclear to cytoplasmatic ratio. It does not have that. Case of Barrett esophagus, metaplasia will have change in the a little bit change in the form of the cell, in addition to change in the type. But the problem with corystoma that it's located in the wrong place. For example, you have gastric tissue located in the distal ileum. This is totally abnormal. I will teach you in the future that there is something called a Meckel diverticulum, which is an outpouch of your intestine. This outpouch will be located near your distal ileum. Remember, the small intestine consists of the duodenum, jejunum, and lastly ileum. So that last portion of the ileum, normally, like in our embryological life, had a connection with our umbilicus. But after we are born, this connection was shut down. And when you close that connection, what happened? You had this one. If it does not obliterate totally, you will get something called a Meckel diverticulum, which is a form of a true diverticulum. Well, the person who said the true diverticulum, thank for me for another real diverticulum in the body. So, because we only have 2 of them in our body, 2 possible diverticulum. So actually 3, but for step 1 you are required to know only 2, which are the Meckel diverticulum and your appendix. Your appendix is considered as a true diverticulum. Okay, the third one you will learn in step 2. It's in the esophagus, but you do not have to know it. It's not Zanker. So, the next one here, it's as follows. You have naming of different tumors. Oh, wait, before I forget. So, inside of this Meckel diverticulum, you can have an overgrowth of what? Of foreign tissue, like gastric tissue or pancreatic tissue. The tissue, or even endometrial tissue. Guys, I said that. Let me say it again. Know that it can have either gastric, pancreatic, or endometrial tissue. I said it. If you get it wrong in your exam, it's on you. I told you. It's endometrial tissue. You will see it in NBMEs, you will see it in New World, you will see it in the real exam. So they are starting to ask now endometrial tissue inside of a Meckel diverticulum. So the next one here, we have the epithelium. So the epithelium goes something like this. If the tumor is benign, we call it an adenoma or a papilloma. So an adenoma, it means that something that is coming from a gland. Make a note about this. While a papilloma, it's something like this. A papilloma, it means that like you have a vessel going in the middle. So imagine like you have a blood vessel here, and on it you have formation of tissue like this. See it? So you have formation of tissue, and in the middle you have a blood vessel. If I cut it like this and I take a look at it from up, it will look like this. Yep, so this is a papilloma, but there will be so many of it. So, we know what is adenoma, we know what is papilloma. Okay, so it ends with oma, it means it's benign. Is that true? Is everything that ends with oma benign? No way. Be careful. It's not always. For example, is a melanoma benign? Melanoma, is it benign? No, it's not benign. Exactly, there's exclusions. So, for example, melanoma, no way that is benign. It's super malignant. So you need to be careful. Okay, so here we have an adenocarcinoma and papillary carcinoma. So it has carcinoma of the name. It means two things. It means it's malignant, and carcinoma means it comes from an epithelial origin. If it was sarcoma, it means it comes from mesenchyme origin. It's important because in the future I will tell you about markers, guys. So let's start with the blood cells. What is a benign tumor of the blood cells? We do not have one. If a patient has a tumor of his blood cells, done. That's a leukemia. So it's a leukemia or lymphoma. The difference between leukemia versus lymphoma often affects actual solid tissue, while leukemia mostly affects liquid tissue, like blood cells, okay? So the next one will be blood vessels. So now we are not going to go too deep in these, it's just like an overview to know the names, you know? So the blood vessels is hemangioma. So the word angio in Latin means vessel. So hemangioma is a benign tumor of the vessels, while angiosarcoma is a malignant tumor of the vessel. The next one is a smooth muscles. This is, the student love to forget this one, leiomyoma and leiomyosarcoma. Keep in mind, make a note that it affects the uterus, okay? So the next one is a striated muscle, rhabdomyoma. Striated muscles, give me two examples of striated muscle. Come on, guys. Two examples of striated muscles. Okay, excellent. Skeletal and cardiac muscle. Do you remember where rhabdomyoma led to a cancer inside of the heart? Did we have rhabdomyoma in the heart, yes or no? We had, yeah, we saw it. So in the atrium, we had a myxoma, while in the ventricle, we had the rhabdomyoma. In the left atrium, we had a myxoma. In the left ventricle, we had a rhabdomyoma. Yeah? And in the right ventricle, right atrium, sorry, we had the metastasis, which was the most common. A most common type of metastasis to the heart is no, it actually skin, melanoma. The most form of heart cancer is a skin cancer that metastasizes to the heart. If you forget about it, it's okay. Just take a look here in first aid. I emphasize it actually. Just a sec. Just a second. I need to find this. Yes, you can see here that if you are asking about the rhabdomyoma, yes, it's in children. Myxoma is more in an adult. So keep in mind that the most common metastasis is melanoma, and it's most likely to go to your right atrium. Okay, so let's go back to neoplasia. Someone just joined. Just a second. Okay. So the next one goes something like this. The next one goes like connective tissue, fibroma and fibrosarcoma. Fibroma and fibrosarcoma. We have the following. Fibroma is mostly a benign tumor of connective tissue. Fibrosarcoma is a malignant tumor of connective tissue. Nothing to know much about. Bone osteoma and osteosarcoma, lipoma, liposarcoma, and as you can see, a benign tumor of the melanocyte is called nevus, and the malignant one is called a melanoma. Is a melanoma really bad? Is it bad? Can it kill someone? It's just like a... Yeah, it can definitely kill. Do you know which organ it loves to go to? except of the heart. It actually likes to go to two organs. Yep, it likes to go to your lungs, your liver, and your brain. So, tumor grading versus staging, this is important. So, there is some words that we are just speaking about now synonyms, you know? So, we are going to say what does differentiation mean, what does Neoplasia mean, what does grading mean, what does staging mean. So, let's take a look at each one of these. Starting with the differentiation, it's the degree to which a tumor resembles its tissue of origin. So, if we say a tissue is well differentiated tumor, it means that it highly resembles the original tissue. Is that a good thing or a bad thing if it highly resembles the original tissue? If the tumor in that organ highly resemble the tissue it originated from, is it a good thing? Yes, it's a really good thing. It means that, well, it's not totally anaplastic. Now we will see what anaplastic means. So, well-differentiated tumor, often less aggressive. Yeah, which is good. They closely resemble their tissue of origin. Whereas poorly differentiated, when you say someone is poorly differentiated, oh, well, that's difficult to deal with. Why? Because they poorly resemble their original tissue and thus they are highly aggressive, okay? And they have really bad prognosis, the ones with the poor differentiation. The next word is Neoplasia. And the Neoplasia, we will speak about it in thyroid especially, and endocrinology. It's complete lack of differentiation. When you take a look at anaplastic tumor of the thyroid, just show it to you. Anaplastic thyroid cancer and thyroid histology. I will show you a normal thyroid histology. This is a normal thyroid histology. You can see and appreciate the colloids here. You can see the cells here. So yeah, you can see a thyroid tissue. Let's take a look now at an anaplastic cell. Man, look at this. This looks nothing like a thyroid. It looks like some weird things. I don't know even what it looks like. If you see something in a tissue that, well, basically looks nothing like that tissue, it means that this is Neoplasia, which is total absence of differentiation of that tissue. So it's a complete lack of differentiation of cells in a malignant neoplasm. So let's speak about grading. So I hope differentiation and Neoplasia make sense. Differentiation, if the cell was well differentiated, it means that's perfect. It resembled the original tissue, and that has good prognosis. While if it was poorly differentiated, that means poor prognosis, and it means that this tumor is highly aggressive. Neoplasia means that there is total lack of differentiation. It's not poor differentiation. There is zero differentiation, which means it does not resemble in anyhow the original tissue, and it's in malignant neoplasms, and they have really bad prognosis. Now let's speak about grading a tumor and staging a tumor. Guys, before I speak about anything, remember that staging is superior to grading. Now I can speak about them. So, grading, a degree of cellular differentiation and mitotic activity on histology. It ranges from low grade, which means well differentiated, to a high grade, which means poorly differentiated, undifferentiated, or anaplastic. So high grade means there is poor differentiation, and low grade means there is well differentiation. You want the tumor to be high grade or low grade? If someone has a tumor, you want it to be low grade or high grade? Low grade. Why? Because low grade means that it's well differentiated. It has much better prognosis. No, it does not mean that we check a stage before the grade, but I'm telling you that the stage is much better a prognostic factor than the grade. Okay? Because like when you check the grade, it might look awesome, it might look well differentiated, but if you have the tumor in every single tissue in the body, that's poor prognosis. So the staging is more important than the grading, but we do both. Okay? Because the grading is easy to do, while staging is difficult to do. You will see why. So it ranges from low grade, well differentiated, to a high grade, which is poorly differentiated. To do the grading, you just need a good pathologist. He takes a biopsy of that specimen, he takes a look at it. He's like, well, this looks like low grade. If you look at the cells here, they resemble the cells here. So yeah, it's a foreign material, but still. It looks bad, but come on, it resembles it somehow. So yeah, it looks more like a benign tumor. While the high grade, you can see the nuclear cytoplasmatic ratio is huge. You can see it does not resemble the cells around it of that origin. And thus, it means that this is high grade. High grade means poor differentiation. Okay, now the staging. So the grade, you can do the whole grading process by using a good pathologist and the light microscopy. That's it. But if we speak about a stage is much more important. Why? Because it can tell you and describe for you three things. We used to describe it something called the TNM system. So TNM system. If you don't know what that is, you must know. So the T is for the tumor size. Okay, so size. Tumor size. The N for node. Involvement of lymph node. And the M for metastasis. Is it going to any other organ? Okay? So, let me tell you this. The stages of cancer, just keep this to the side, the stages of cancer are subclassified to stage 1, 2, 3, and 4. If someone has a stage number 4, this is really bad, he's going to die for 100% chance. He's dead. Stage number 3, there is really high chance it's becoming 4 and he's dead. Stage number 1, there is high chance that he will fully recover and just remember it as a really bad memory. Case number 2, with the proper chemotherapy and radiation, there is high chance it can go to stage number 1 or even recover totally. But stage number 3, it's really late. But stage number 4, it's just like matter of weeks. That's it. So if someone, look at this, this is important. If someone has M1, which means that normally the M should be 0 and the node should be 0 and the size should be 0. Okay, this you can play with these. Like if you have M1, each organ is different. That's good because it means you don't have to memorize all of them. But if M is 1, that means this cancer is class 4. Done. Okay, this is stage 4 already. If there is metastasis to any organ, you don't have to check anything else. If there is metastasis to any organ, this cancer is a stage 4. The patient is going to die. So stage, degree of localization and spread based on the site and size of the primary lesion. So spread to the lymph node, which is the T, and the presence of metastasis, which is the M. Based on the clinical and pathological finding, you will see what that means. There is the C versus P, which we use, like for example, if you take a look here, they write C T3 and 1M0. What does that mean? According to the clinical finding, C is for a clinical. According to the clinical finding, T is a 3, which is the size of the tumor. It's like 3 big. Involvement of the lymph nodes, he was able to palpate one enlarged lymph node that is not tender, which is suggestive of tumor. And M is 0 because he could not see a metastasis on a clinical finding. But maybe the pathologist will not agree with that. We will see. So there is based on a clinical or pathological, and according to what is based on, we put either C or P. So stage generally have more prognostic value than a grade. So that's what I told you guys. Stage is more important. High stage yet low grade tumors is usually worse. So if you have high stage but the tumor grade is low, again, do you want the tumor grade to be low or high? Right, low or high? What do you want the tumor to be? Low grade or high grade? Low grade, yes, because low grade means well or bad differentiation. Well differentiation, exactly. So you want it to be high stage, they tell you here a high stage yet low grade tumor is usually worse than a low stage high grade tumor. So if the tumor is really messed up, it's anaplastic of the thyroid, but it's only in the thyroid and not going anywhere else, literally going nowhere else. If you remove the whole thing, the whole thyroid, you saved his life. But if the patient has like a tumor that is not that bad looking, but it's literally in every tissue in his body, he's going to die. Why? Because the stage is high. So they write here is stage determined survival. So S for S. TNM staging system, the stage determined the spread. So the T is for the tumor size and invasiveness, and the N for the node involvement, the M for metastasis. Each TNM factor have an independent prognostic value. N and M are the most important, and M is the most important. But if you don't have M as an option, choose N. For example, if they tell you which of the following is the most important prognostic factor, and you have the answers, the size of the tumor is 12 centimeter. That's answer A. Answer B, involvement of the axillary lymph node. Answer C, involvement of the widespread like involvement of the liver, which is the primary tumor was in the liver, you know. So don't let them trick you. If the primary tumor is like metastasizing but within the same organ, this is not metastasizing, this is just spreading. Metastasizing is movement from one organ to other organ. So if we speak about the most important prognostic factor in this case is spreading to the lymph nodes, okay? So why? Because no metastasis. So look here, the T for the tumor size and invasiveness, as you can see, it has invaded the basement membrane. The N for involvement of lymph node, while the M is blood or lymphatic vessels and the spread to other organs. So let me ask a few questions just to make sure you guys got what I was speaking about. If I say that a tumor was successful to invade the basement membrane, what do you need to invade the basement membrane? Which enzyme help you to invade the basement membrane? Okay, you need to disrupt the EC adherent to reduce the binding between the two epithelial cells. That's correct. And also you need the metalloprotease. Why the metalloprotease? To degrade the what? Basement membrane. Yep. Excellent. Okay. Let's just do the hallmarks of cancer, and then I will tell you, before we do the hallmark of cancer, I'm just going to tell you something really quick. Guys, see this page, immune checkpoint interaction. The guy who won the Nobel Prize for 2019 or 2020, I'm not sure. Either 2020 or 2019, one of them. I think 2019. Yeah, 2019 for sure. The guy who won the Nobel Prize for 2019, he won it because he discovered this thing. So we are studying the most cutting edge medicine, guys, with you. So we'll speak about that after the break. But for now, let's speak about the hallmark of cancer. So the hallmark of cancer. So the hallmark of cancer is is caused mostly acquired by a DNA mutation. Oh yeah, 2018, excellent, thank you so much. So DNA mutation that affect the fundamental cellular processes. So basically what leads to the cancer? Think about it, guys. You have a DNA inside of the cells that is programmed to make you that one cell that you need. But that process gets disturbed. You have hyperproliferation of the cells. If you have hyperproliferation of the cells, cancer can occur. Okay? So they write here DNA mutation that affect fundamental cellular processes like growth, DNA repair, or survival. If the cell can survive much more than it should, the patient will have the cancer. So now let's speak about how these cancer happen. So the growth signal signal self-sufficiency. This is super important. So let's start with it like this. I just uncovered my wrist because this is going to get dirty. So let's take a look. Okay, inside of your cell, oh yeah, it's really interesting topic. So starting with our cell, if we imagine that we have a cell, let me just do this. Okay, yep, just needing to clean everything. Okay, so if we have a cell here, let's just put a cell here, and this cell want to grow. How a cell decide to grow? Well, how we have division of the cell and the creation of a new baby cell. Well, actually, this is like, first of all, you have a receptor, okay? And this receptor, you have binding of something into it. It could be like a growth factor, for example, okay? Let's say that for now it's a growth factor. This growth factor will be activated, okay? When it will be activated, what will happen? That receptor will activate inner signaling inside of the cells. For example, one of the many signaling molecules, one of them is called RAS. So when that RAS gets activated, he will go and be like, proto-oncogene, can you be active for me, please? Be like, why I would like to be active for you? It's like, because I said so. So the RAS basically controls the proto-oncogene. We'll speak if it inhibits it or activated later. This is irrelevant. But what you must know that there is the following stuff we have to make proliferation of the cell. Receptor of a growth factor. Signaling molecule like the RAS. Proto-oncogene, okay? Which is basically genetic code that gets encoded. Transcription factor like the MYC. These MYC are transcription factor that leads to that initial portion of the DNA to be encoded basically. Cell cycle regulators, which are these police cops that decide how fast the proliferation should occur. So why I told you all of this? Because in different words, I'm telling you, if you mess up your receptor, the patient can get cancer. If you have hyperactivation of the receptor, the patient can get cancer. If the patient has so much proto-oncogene, he can get cancer. If he has so much growth factor, he can get cancer. If he has so much disturbances of the RAS activity, well, basically that signaling molecule, he will get cancer. If the transcription factor that controls the transcription, which means the gene expression of the proto-oncogene will be over-proliferating, the patient will get cancer. Also, cell cycle regulators, which decide how much proliferation you will have. If these are hyperactive, the patient will get cancer. So as you can see, this growth signal self-sufficiency pathway is super important. So mutation in gene encoding for the proto-oncogene can increase your growth factors. If you have more growth factors, what will happen? So proto-oncogene create for you growth factor. A growth factor comes and activate the cells. Activation of the cells lead to what? Activation of the cells lead to what? It will lead to activation of signaling molecule. Activation of the signaling molecule lead to what? Activation of the proto-oncogene. Activation of the proto-oncogene, growth factor. Growth factor, receptor, signaling molecule. Keep going. You have created a cycle. This is how cancer cannot be stopped. Well, you are like, okay, I see a problem, but I see an opportunity. Well, if I cancel working of one of these guys, if I inhibit this receptor, for example, can I treat cancer? Think about it, guys. If I just block this guy, can you treat cancer? Yes. Actually, well, it's actually possible. But the thing is, you will decrease the proliferation, you will not totally stop it. And we have an example of an actual drug we are going to speak about. Like in chronic myelogenous leukemia, we, as a human, we already have invented this drug. I'm not speaking about science fiction. We already use it for the treatment of these patients, which are all of these drugs, like they are tyrosine kinase inhibitor, ends with a TNIB, used for CML. Okay, we'll speak about them later. But overall, I just want you to be comfortable that if you have a problem with the proto-oncogene, growth factor receptors, signaling molecules, transcription molecules, or the regulator of the cell cycle that I will describe deeply, if you have any problem in these, the patient will get cancer. Okay, let's go back. They write here, more growth factor, autocrine loop. Autocrine, it means it activates itself. So, for example, one example of these are the BDGF and the brain tumor. Platelet-derived growth factor. You are like, oh, platelet-derived growth factor. Well, which tumor it's going to be? Is going to be platelet tumor? No, it's not going to be a platelet tumor. Because this platelet-derived growth factor can lead to different brain tumor. For example, there is one tumor called Glioblastoma Multiforme, which is really bad. This Glioblastoma Multiforme, it tends to be one of the worst prognostic tumor in a human being, like in an adult. So this is like the nightmares of every person. So this is what medical student, when they have headache think they have. It has this butterfly appearance. It can spread from one lobe to other lobe, and it kills the patient within a year. It leads to really bad headache. And guys, as I told you, I will be teaching you some clinical stuff. Not every time you have headache, it means it's a tumor. Yeah, this is you can try, but so far everybody dies. You can prolong the life of this patient. We have drugs for that, like you can prolong it for 1 to 2 years, but overall it's not that perfect. Also, you can put like radioactive substances that is placed at the place of the tumor, and they help like just locally irradiate the tumor as well. But still, it kills. So let's go back here. So platelet-derived growth factor is the glioblastoma multiforme. I told you I'm going to teach you some clinical stuff, guys. So look, if you have a patient that comes to you and tell you, I have this really bad headache, doctor. I think I have a brain tumor. The first question you are going to ask him, when does the headache occurs? If he tells you, well, my headache especially occurs when I come back from work, you look at him and tell him, okay, this is not a brain tumor. A brain tumor will lead to a headache in the morning, mostly around 5 o'clock in the morning, and the headache will be so bad, it will wake you up from sleep, okay? If you have that characteristics of tumor, you get an MRI. Otherwise, you don't deserve the MRI. You deserve a massage to relax yourself, because that's tension headache. So, the next one is the following. The growth factor receptor, like a constitutive signaling, like the HER2 in breast cancer. Remember, never trust her. So that's in breast cancer. This will be super important. This is my mnemonic. Nobody steal it from me. Never trust her. Why never trust her? Or trust her if you want. So trust her because trastuzumab, which is the drug that works against the receptor HER2. Done. So the growth factor HER2 has a drug that we have invented that can work against it. And that drug name is trastuzumab. So trust. Yeah? Not trust in breast cancer. So signaling molecule include the RAS. RAS will take a whole day explaining. And the transcription factors, MYC. The MYC family. We have the c-MYC, we have the n-MYC. We are going to speak about all of them. Guys, I have to say, sorry, but I love cancers. They are really interesting topic because it makes you understand that there is actually a lot we can do about cancer. Not like what we learned during our childhood. A patient gets cancer, he's dead. I want you to know, guys, 20 years from now, 20 years back, if 4 people got cancer, only 1 survived. right now, this day, if 4 people get cancer, 3 of them survive. The treatment of cancer has progressed significantly. It's not like how it used to be 20 years ago. So, cell cycle regulators include the cyclins and the CDKs. We are going to speak about them in hematology, but I will not allow just to speak about them in hematology. I will speak about them twice in the Neoplasia chapter and in hematology again. So, there is like different cell cycle regulators. This is the cell cycle, which basically means that your cell, to make new cells, has to go through multiple phases to make more cells. See? So it starts here, and you can see here the G0. It's the resting phase where the cell never divides, and some cells are always there, like nervous tissue cells, like cardiac cells, like musculoskeletal cells. Let's say that you have normal liver cells. Maybe it can be resting, but it can super easily go to G1 phase, which means it's a proliferating phase. So from G1, we have a police officer called the B53 and the RB. They are a checkpoint, okay? And they control the progression to the S phase. S is for synthesis. Synthesis of what? DNA. So you are making DNA and another genetic material. As you can see, initially you only had 2 strands, and now you have the whole thing, which we utilized when? In the G2 phase, which is the double check repair at the G2 phase. And after that, the last thing you have to do, well, you already have 2 genomes. So what to do with them? Mitosis. You divide them into 2 parts. Okay, so what is the big of a deal? Well, these police officer, if you deactivate them, there will be no control over the cell cycle. So you will be going through the cell cycle much more faster. Imagine this. Go much more fast. Each time you go through this, you make 2 cells. So 2 cells, 4 cells, 8 cells, 16 cells, 32, 64, 128, 256, 512, 1028, and like that. You are moving fast. This is a tumor. Guys, a common question on the Usmle. How many times you need to divide a tumor until it becomes clinically significant? Like, how many times a tumor need to divide until you are able to palpate it? "30 times. You must know the numbers. It's 30. 30 times. If the tumor divides 30 times or more, it becomes palpated most of the time. So, or start exerting like clinical symptoms. Most of the time, not always, because some tumors can be in cavities and they can grow 100 times before you detect them. So, okay, that was for the cyclins and the CDK. So, anti-growth signal in sensitivity, so mutation in the tumor suppressor genes like the RB. Remember the RB, I just showed you it. It was after the G1 phase. And it was controlling the progression of the cell cycle. And if the RB is messed up, you can think what will happen. There will be, the police officer is dead. So you will just be going really quick inside of the cell cycle. More going through the cell cycle will lead to hyperproliferation of the cell. Hyperproliferation of the cell lead to cancer. Yeah. Also, loss of the E-cadherin function. So E-cadherin function, it's basically the E-cadherin. It used to do what? It used to bind to. It used to adhere to epithelial cells together. And if you remember, like I told you, like we had 2 epithelial cells, and between them we have this cadherin. If this guy is downregulated, the cell will start to divide from each other. So the cells, the tumors can just descend downward. It will just facilitate the way of the tumor. So they write here, loss of E-cadherin can lead to loss of contact inhibition. Like in case of neurofibromatosis type 2 mutation, that case will occur. We'll speak about that when we speak about neurocutaneous disorder in neurology. Okay, so for now, I just explained these 2. Let's take a little break, then come back and explain the rest of them. And then I will make a little poll to decide if we should do more cancers today, or should we... Oh, no, actually, no. I will just finish this, and then we'll start the review for CVS to close it up and not look at it again, except before your actual exam, guys. Okay, so until maybe, hopefully, somebody else will write more questions. If not, I will keep doing the tumor stuff. So, moving on, speaking about evasion of apoptosis. Apoptosis was like the cell death, which was a normal physiological process that normally occurred in our body. And it was really like, it was good. It prevents autoimmune diseases, it prevents cancer, so it seems like a really good deal, you know? But what is the problem? You can evade it. How can I evade it? Well, take a look here. If you remember when we spoke about cellular pathology, we spoke about this area. Yes, this area. In apoptosis. If you remember, I told you back then that the mitochondria, if we imagine that this is a mitochondria, let's imagine that this is a mitochondria. The mitochondria had a protective proteins on the walls called the BCL2s, yeah? So here is the BCL2s. They are a protector proteins. And we have another proteins who were evil. They were like the backs, yeah? And the back. So these were evil. They wanted to destroy the mitochondrial membrane. And the BCL2 protects the mitochondrial membrane, yes? Actually, this is a continuation of a story. The mitochondria was going to be destroyed by the backs and the back, but the BCL2 are protecting it. If they overprotected, let's imagine this, they overprotected. If you have overexpression of the BCL2, you will have overprotection of the cell, yeah? So of the mitochondria. That's perfect. So that means your mitochondria will become immortal. Is that a good thing or a bad thing? If your mitochondria becomes immortal. Oh yeah. Exactly. It's a really bad thing. Look, if you have so much BCL2, look what happens. So much BCL2, your mitochondria will be 100% protected. If it will be 100% protected, the backs cannot go inside, okay? So the mitochondrial membrane will not be affected. If the mitochondrial membrane cannot be affected, you will not be able to release the cytochrome C. If you cannot release the cytochrome C, you will not have activation of caspases. If you do not have activation of caspases, you will not have apoptosis. If you will not have apoptosis, the patient will have cancer. So, overexpression of the BCL2 molecule can lead to formation of cancer due to poor mitochondrial apoptotic pathway. The apoptosis will not work via the mitochondrial pathway. The second way it's going to lead to cancer, basically, you can see here something called the B53. If the B53 is not functional, zero function, there will be no backs or back, none of them. If you don't have these due to a mutation of the B53, what will happen to the apoptosis? Will it increase or decrease? Decrease. Less apoptosis means cancer, yes? So the backs and the back will not be there. Cytochrome C will not be released. Caspases will not be activated. The cell will be hyperproliferating cancer. I hope that this topic is interesting for you guys. It's super, just like it's building concepts for now. So let's go back here. So they write for us a mutation in the genes that regulate apoptosis, like the B53, we just saw that, and the BCL2 can lead to cancer. For example, mutation of these guys can lead to follicular B-cell lymphoma. So the next one is limitless replicative potential. Well, there is something called a telomerase. What is a telomerase? This is actually a real story. Here is what, first of all, let me tell you what is telomerase. They do ask about them in the exam a lot. If this is a DNA molecule, okay, double-stranded, blah, blah, blah. Now you have like the 3' and you have the 5'. The telomerase like to bind where? to the 3 end. If you forget about it, just remember like this. Telomerase is a 3, it's T for a 3, okay? So it binds to the 3 prime. They ask this. What is the function of the telomerase? It prolongs the strand. Why would I prolong the strand? Because each time you express a strand, in the genetic expression, you lose a little bit of it, okay? So eventually it's going to become less and less and less and less and less and less until the patient dies. So what do? Each time you lose a little bit of a portion of it, you lengthening it, okay? So you make it longer with telomerase. But it does not go to the previous size. Like in childhood, it's like this, then it becomes like this, then it becomes like this. So yeah, in age, by age, it will become shorter anyhow. But the telomerase, try to recompensate for it, like more or less, okay? So, if that is the case, yes, so if that is the case, if this strand becomes shorter with age, it's totally correct. Telomerase try to help, he's not perfect, he will not do it for 100%. Some cancer cells have a lot of telomerase. Excellent, so they will not age. Yeah, they will not age, not you. So the cancer cell, you will still age. They will never die. It's ridiculous. If you bring them and put them in a media, like in vitro, in the lab, and you put cancer cell in this media and you just give them glucose, they will come back in a few days and they will fill the whole plate. They will never die. They are immortal. Why? Because if you take a look at the length of them, it's super, super long. Yeah. So you must know about one thing regarding this telomerase thing, guys. Well, it makes it longer. That means the cell will become immortal. It will not die. This is important. Well, why did I mention the thing here that sounds like an agar? Yeah, it sounds like a bacterial media, you know? But it's not bacterial, it's a freaking cancer. Well, because this is important. Look, guys, if I have the cancer, if I have the following, I bring 4 medias, okay? It's not done for every tumor, but some tumor we do it for. So that's why I'm telling you. And I put here cancer cells, cancer cells, cancer cells, cancer cells. And then I add to them what? I add a little bit of the first chemotherapy. And here I add the second chemotherapy. And here I add the third chemotherapy. And here I add the fourth chemotherapy. Okay? After a few days, I come back. Okay? When I come back, I discover that this has happened. So, what does that mean? It means that the drug B, which is this one, the drug that was used here, will help the patient in chemotherapy, while the other ones, for this exact tumor, they are completely useless, okay? So for that patient, I would like to use this drug on him, not these, okay? Oh my God, Nobel Prize is coming, one over the other. Can I get one? So, next one. So, I hope it made sense so far. Now we speak about telomerases. Oh, yeah, that's a good idea. Thank you. Well, we have here, yes. We have reactivation of telomerases, maintenance and lengthening of the telomeres, which prevent chromosomal shortening and cell age. There is one disease you must know about that have absence of the telomerase. In one of these, there is one genetic disease. If the patient have it, his telomerase will basically be down-regulated, and they will look like they are really old when they are really young. That seemed like I said that wrongly. So basically, this patient, when they are, let's say, they are 15 years old, and you look at their shape, their body, they look like they are 60, okay? Why? Because their telomerase is deficient, okay? So that's an interesting fact. Well, sometimes they can make it up to 15. I will show you a picture about it. Just a second. I'm trying to oh yeah, here it is. Come on. Yeah, exactly, Bulgaria. Yep, you can find it in the new first air. Telomerase, they write down-regulated and in aging and Bulgaria. So let me show you a patient with a Bulgaria for you guys who do not know what a Bulgaria is. Take a look at this. See this little cute girl? Maybe she is like 2. She looks like her face shape, her wrinkles, all of that stuff make her look like she's old. But in fact, she's really young. Why? Telomerase deficiency. So from now on, you know what is this telomerase deficiency. They have really quick aging and they die really quick. So you must know about this one and no way to treat them. So interesting enough, there was a study about this disease with cancer and like if these patients do have cancers, and turns around that they have less risk of cancer than other people because they have less telomerases. So, okay, that was just for extend knowledge. Let's speak back about the limitless replicative potential. So that was telomerase. I hope that made sense. Now we are going to speak about sustained angiogenesis. For the cancer to keep going, he needs blood supply, constant blood supply. The more blood you give him, the more energy he has, the more work he can do. So sustained angiogenesis is vital for him. So an increased pro-angiogenic factors. Pro-angiogenic means that are factors that can lead to excessive making. Which one? Okay, so what is telomerase? So if we imagine that this is our chromosome, let's just make it as one strand for now, just for the sake of simplicity. Each time I'm going to do gene expression, which is like, this is a DNA, I'm going to make from it an RNA, and then I'm going to make from it a protein. This process of gene expression, each time it happens, you lose a little portion of your DNA. So yeah, you lose this part, okay? When it happens again, you lose a little bit more because the DNA polymerase bind there. And each time you will lose a little bit, and that's why we age, because our DNA is becoming shorter and shorter. So there is these particles called telomerases. They are fixed portion of DNA that comes and add up to the 3 terminal, okay? So the first time you add one, you add one. As you can see, the DNA has a prolonged, but it's not as long as it used to be. So it's not perfect, but it's better than nothing. So what happens then? In case of telomerase being so much, you have so much telomerase, the cell will have so much DNA. Well, that's good. We will have an infinite amount of DNA. Yes, that means that you will have an infinite amount of replication. So you will have a lot of DNA, a lot of RNA, a lot of proteins, a lot of cells. A lot of cells with the DNA, a lot of cells with the DNA, hyperproliferation of the cells. Proliferation of the cells lead to cancer. So again, more telomerase, more DNA. More DNA, more cells. More cells, more cancer. Okay, more cancer cells. While here, the pro-angiogenic factors like the VEGF, it's basically a growth factor that helps you make vessels. So, or decrease in the inhibitory factor. There is some factor that prevent you from making vessels. So if these are decreased, also you will have more proliferation of the vessels. So factors may be produced by tumor or stromal cells. Okay? Vessels can sprout from exiting capillaries in new angiogenesis, or endothelial cells are recruited from bone marrow, which is like basically vasculogenesis. So let's speak a little bit about this. So if you have a new vessels making, to be able to reach the tumor, we call it a new angiogenesis. A new, it means a new, angio means vessel, genesis, it's like making of the new vessels. Exactly, that's why we make an anti-angiogenetic drug. And guys, what does the word genesis mean? It's the process of making something. That's why my company name is Medicogenesis, the process of making great doctors like you guys. Okay. Or endothelial cells are recruited from bone marrow, which is like you have some endothelial cells that come from the bone marrow that make you big vessels. That's the difference. There is making of capillaries and there is making of big vessels. The big vessels, it comes from endothelial cells that has been recruited from the bone marrow and went outside. So here's the thing. If you make so many new vessels, will they be 100% perfect, or you have more risk of mistake if you make so much new vessels? Mistakes occur. The type of mistake that will occur, that they will become much more leaky, okay? And if they are more leaky, you are like, okay, what is the big of a deal? If they are more leaky, they can leak what? The tumor cells. They can separate it all over the place, yeah? Okay. So that's for angiogenesis. Okay. So, well, tissue invasion, loss of E cadherin function. It's it's losing of the intercellular junction. So remember, the E cadherin, it used to be the cells that used to connect two cells together, yeah? So if you, and they used to connect together using the cadherin. If the cadherin does not exist, what will basically happen that the epithelial cells will separate from each other, and that will lead to movement of the tumor cells downward. So there will be loss of the intercellular junction. We spoke about this. Then comes the job of metalloproteases, which are enzymes we spoke about, like collagenases, which what was their function is degradation of the basement membrane. Guys, which type of glycogen is located in the basement membrane? Collagen, what is glycogen? No. What type of collagen is in the basement membrane? Yeah, exactly, type 4. Excellent. So, as you can see, metalloproteases degrade the basement membrane and the extracellular matrix. So cells attach to the extracellular proteins. So after, okay, let's speak about it step by step. So first of all, we had two cells and they were attached to each other by what? By a little E cadherin, yes? And now this was downregulated, okay, and then we had this basement membrane under it, and that was degraded by what? By the metalloproteases. So here, first of all, we had the cadherin. These went down. Excellent. Next, collagenases inhibited the collagen type 4. Next, you have some particles here inside of your matrix. They are called laminin and fibronectin, if I'm not mistaken. So these laminin and fibronectin are extracellular. They are under the basement membrane. And when what happens that the cells inside, like the tumor cells, bind to them, to the laminin and the fibronectin. And when they do that, there will be cell migration, okay? And they will have this movement from the tissue into the extracellular matrix, which is this area, extracellular matrix. So the tumor cells will be like, let's imagine that we have a tumor cells here. She's like, she want to go inside of the extracellular matrix. Okay, she's like, can you let me in? Can you let me in? It's not letting her in. It's like, okay, let me downregulate this. So this is downregulated, which is the cadherin. Now she's like, well, can you now let me in? He's like, yeah, sure, I can let you in. But then she cannot pass. Why? Because of the basement membrane. So who comes? collagenases. So these collagenases do what? Degrade the basement membrane. They are like, oh, that was a long journey. Well, do you let me in? Of course I can. Can you let me in? Of course I can. Oh, finally, freedom, extracellular matrix. What should I do? What should I do? Oh, fibrinonectin, let's start dating. So they will go to fibrinonectin, laminin, they attach to them. Okay, well, this is my locomotion. I will live here and build a family. And my family is going to build a family. And let's start separating all over the extracellular matrix and invade the whole thing. You know what? Let's even buy a new blood vessel for us to be able to travel all over the body, to see new planets and new places that we will never forget about. You go to the lung. You go to the kidney. You go to the liver. So you see how the process from one area, exactly, they do whatever they want now. You go there. And they are like, wow, looks so comfy. Well, what is this? Lymphatics. You know, guys, if you are a carcinoma, you don't like blood, we know that. Maybe you want to go with the lymph. Okay, so you go to the lymph. After they enter the lymph, they go to the blood and also go and separate inside of the body. Okay? Okay, so far so good. I hope, guys, you are enjoying the tumors. So, and then there will be vascular dissemination, as you can see. So cell migrated through the degraded extracellular matrix. They create locomotion, which is like a new environment for them to live. And then finally, they have vascular dissemination all over the body. The next step is metastasis, which is a tumor cells or emboli spread via the lymphatics or the blood. Adhesion to the endothelium, extravasation and homing. What is that? It's the process that I just told you. There will be adhesion to the endothelium, extravasation from the vessel, what happened here? Take a look, guys. So the tumor cells moved inside of the circulation. It's now inside of the blood or inside of the lymph, which will eventually go inside of the blood, because, like the thoracic duct thing. Now they will go to the target organ. So remember, I told some of them to go to the kidney, the liver, and other organs. If we say that this is the liver, and this tumor cells come, and she's like, oh, finally I made it to the liver through the blood supply. What should I do now? So this is the liver, and here you have what? The blood vessels that she's inside of it. Yeah? And here you have the cells of the liver, basically. Yep. So, and here you have like cells of the liver. So what this tumor cells must do to get into the liver? It must do the following. It must adhere to the endothelium, extravasate, and home. What does that mean? First of all, it binds to the epithelial cells, which are cells right here. So they go and adhere to it. Okay, I adhered. What else should I do? Well, after you adhere, you must make relationships, which means you need to speak and secrete some enzyme, decrease the cadherin between the cells, and then go deeper, release some collagenases, which will degrade the basement membrane, and then go really deeper until you reach the laminin and the fibrinonectin, and then start a new foci here, a new family here. Yes? And that's how can a tumor cells move from organ A to organ B to lead to a metastasis in the organ B. So they write here, site of metastasis can be predicted by the site of the primary tumor, as the target organ is often the first encountered capillary bed. Some cancers show organotrophism. Lung cancers commonly metastasize to the adrenals. Let me tell you a little bit about what they just said. So, guys, if someone has colon cancer, let's take a look at this. If you take a look, If you take a look at the circulation inside of the portal system. The portal system It's basically getting like draining blood from the colon to the liver. So if the patient has a colon cancer, what is the first organ to get the cancer? What is the liver. The liver. Look, guys, it's pretty simple. It's the first organ that the cancer will encounter. So if you imagine that this is the cancer cell and it was in the colon, it will do all of this process of decreased adherence, basement of the passage of the basement membrane by making the collagen, and then it will go inside of the circulation and be like la 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 until it reaches the liver. And the first foci to go, it will be in the liver. Okay, let me give you another example. You can see here that the inferior vena cava attaches to the liver, and then if it keeps going to go to the right heart and then to the lung. So a lot of actually liver cancer can go to the lung. Why? Because it goes with their circulation. Okay, so and some cancers for some other reason have a tropism. So the word tropism means they like that thing, tropism, which means like this cancer has a tropism to adrenals. It like adrenals. Why? Because it has some form of receptor there or something like this that it makes him more likely to affect that area, not related to a blood supply. Okay? So, for example, the lung, like the adrenals, there is no actual direct contact between them, but they like it. Probably there is some form of receptor for the lung cancers there, and that's why they like to go there. So you must just know the word tropism, and there is a few cancer you will learn, and each one of these will be highly specific for that area. Okay, the next thing, Warburg effect. It's shift of a glucose metabolism away from the mitochondrial oxidative phosphorylation towards glycolysis. What does that mean? So, guys, why do we breathe? Why do we breathe? We breathe to get oxygen in. I love this answer. Why the hell we need oxygen for? Well, we need it for the electron transport chain. What is electron transport chain? Well, electron transport chain is the stuff that makes us ATP. How? Well, I'm asking a lot of questions. Well, it's a long story. Look, we call it internal respiration or cellular respiration. Well, back in the time, there was something called glucose. And that glucose entered a process called glycolysis. Okay? Glycolysis. That glycolysis in the end made something called acetyl-CoA. That acetyl-CoA is going to make you have acetyl-CoA from the glucose. That acetyl-CoA is going to enter something called the TCA cycle, which is the same as the Krebs cycle. That Krebs cycle, I'll be explaining for you later, then will enter something called electron transport chain, and then that will activate something called oxidative phosphorylation. Oxidative phosphorylation, which makes you ATP. So the main goal of a glucose is to make you ATP. To do that, the electron transport chain has multiple complexes inside of it which help it to function. One of them is called complex 4, which contains cytochrome oxidase, and the O2 function there. Without him, you will not have ATP. So it's really important. So that's why we need the O2 to make ATP out of it. And in case of a tumor cells, would you like to have a glucose really, really quick or delayed? You need it fast or you need it slow? Well, you want to delay it, but the tumor wants it fast. You want it to be delayed, but the tumor wanted to get it really, really quick. If the tumor wanted to get it really, really quick, there is two ways to get ATP. The first way is the long one I just drawn in black. So the short way is from a glucose, you can go through something called anaerobic glycolysis, which means it does not require oxygen, and you can make less ATP, like just a couple of ATPs, okay? Just 2 ATPs, actually 4, but you consume 4 during, you make 4, but during the making of this process you consume 2, so you are left with 2, okay? So, but while in this area you make like 32. This is much more. But for a cancer cell, he wanted a quick and dirty, which is like he wants these two. So there will be a lot of anaerobic glycolysis happening in the cancer cells. Well, as you can see, guys, who is more economic? The oxidative phosphorylation, the long process, or the short process, the anaerobic glycolysis? Who is more economic? Economic, I said economic, which means no, actually the short is not more economic. Why? Because this one glucose is giving you 32 ATP. But if you use the short pathway, one glucose is making you 2 ATP. This is not good. This means that you will deplete the glucose in the body really, really quick. Yeah? Because you will be utilizing 15 glucose to make the same amount from 1 glucose. So for 15 glucose, you will make, 16 glucose, you will make 32 ATP in case of anaerobic glycolysis. And to make 32 in case of aerobic glycolysis and oxidative phosphorylation, you need only 1 glucose. So you can imagine a patient who have cancer and he's mainly doing anaerobic glycolysis. He will be fat or thin? Thin, because he's consuming ridiculous amount of glucose. He's consuming so much glucose, he's becoming cachectic, we call it, or really thin. Why they become thin is many reasons, but this is one of them. So here they write, shift of a glucose metabolism away from the mitochondrial oxidative phosphorylation towards the glycolysis. And we call that the Warburg effect. It's what I just showed you. The last thing I'm going to tell you is about the immune evasion in case of cancers. How can the cancer run away from the immune system? Well, they play hide and seek. So normally the immune cell recognize and attack the tumor cells. Who do that? Cytotoxic T cells. Cytotoxic T cells is just like a psychopath moving around in your body, and he has a gun. He has a gun, okay? That gun secretes a gran enzyme and the perforins that can destroy literally any cell. And he also has another hand that has like a glove, and he has the fast hand on it. So if he say a cell he wanted to induce apoptosis in it, he can connect his fast to the fast receptor that induces extrinsic apoptosis. So you can see here, normally immune cells can recognize and attack tumor cells. For successful tumorigenesis to occur, a tumor must evade the immune system. Multiple escape mechanisms occur. Well, the first way first is the decrease of the MHC class 1 expression by the tumor cells. You are like, wait a second, what is MHC class 1? It basically stands for the major histocompatibility type 1. And you are like, well, like that helped. What does it mean? Well, basically, how our body knows that these cells belong to us. In each of our cells in our body, we have MHC class 1, which is basically like a receptor, okay, guys? And this receptor has like an exact sequence that is for us and not for another human being. And our immune system know it. So whenever this cytotoxic T cells, it see it, you know, and she's like, oh, yeah, exactly. All of the nucleated cells have it, but you must know that few cells do not have it, the ones without a nucleus, like the RBCs and the platelets. So here you have like, he still have the gun and he still have the fast hand, yes? And he's moving around with them. But he does not kill these cells with the MHC class 1 because he recognizes they are from our body. So what happens? Here they tell us, the first way to evade the immune system is decreasing the MHC class 1 expression by the tumor cells. So the cytotoxic T cells are unable to recognize the cell tumor. So this cytotoxic T cells is a pervert. It touches every single cells, and she's like, oh, let me touch your MHC class 1. And when it touches it, if she feels it, she feels, okay, this is our body, we need to keep it. But if she feels that it's weird, it's for a tumor cells, for example, or it's abnormal, it's not like a human body, you are like, she's like, wait a second, this feels weird, kill it. So she will kill it with the FAS or with the grand enzyme. And then she will go, why? Because it was altered, it looks weird, okay? So it could be a tumor cells. So yeah, it was a good idea, she killed it, it was a tumor cells. Then it goes to our normal body cell. It's innocent. It has an MHC class 1 that is intact, it's not affected. So when it comes to touch it, she is like, oh, this is okay, this is our body, let's keep going. So tumor cells secrete immunosuppressive factors. You're like, wait. Are you telling me that the tumor cells have an immune system that protect them from us? Exactly. So the tumor cells secrete immunosuppressive factor, including tumor growth factor beta, and recruit. Yeah, no, not like that. They make TGF beta, which recruits the regulatory T cells to downregulate the immune system. You're like, what is this regulatory T cells? Pretty soon we will be speaking about the immune system. And in the immune system, I will be telling you about the Treg. The Treg, it does secrete TGF beta. See, TGF beta from the tumor cells lead to activation of the Treg. Treg makes you another time TGF beta, interleukin 10 and interleukin 35, which lead to down expression of your immune system. They make your immune system calm down. So that when your immune system calms down, he will not be fighting the tumors. If your body is not fighting the tumors, the cancer will thrive. So tumor cells upregulate immune checkpoints molecule, which inhibits the immune response. So these guys are good. So you remember the cell cycle? We said that the cell cycle, where is it? Yeah. The cell cycle, if it happens really quick, we have formation of tumors, yeah? So the cancer recognize this. So they are like, well, okay, so if this goes really quick, we will have so much of our cancers. We want that, but we are afraid that this human being, is going to make a lot of immune cells by moving really quick in the cell cycle. So guys, let us do like this. I'm speaking in the name of the cancer cells. Let's do something like this. Well, let's make hyperproliferation of the cell cycle during when we work. But when the immune system wants to work, in his cell, it creates for us so many police officers that will make it really difficult to move in the cell cycle. See, he will not be able to move in the cell cycle, so the immune response will be really poor because you do not have enough cells. Well, cancer cell, you sound really evil. I know. Thank you so much. So that's how these are all of the hallmarks of the cancers. So again, let's speak about the last one, about the immune evasion in case of cancer. So you have something called the cell cycle. So the cell cycle does something like this. Normally, cell cycle, each of our body cell has a different cell cycle. It doesn't mean that all of your body has this exact same cell cycle. This is not true. So in some portion of the cell cycle, we have regulatory enzymes that tell you that allow you to move forward or not to move forward, okay? So if we speak about the case of tumor cells, in case of tumor cells, let's imagine that this is the cell cycle of the tumor cells. What will be the velocity of the movement of going through the different areas of the cell cycle? Keep in mind, if you pass one time through the cell cycle, you have a creation of 2 cells, okay? So, will you want to go really, really quick to make more tumor? I'm not speaking about you, I mean the tumor. The tumor go really quick or really slow inside of the cell cycle? Quick. Why? Because he want to make more tumor, yeah? He goes really quick, as fast as possible, so I can make more tumor. I guess some of you don't know what is cell cycle. That's the problem. So cell cycle is basically it's how your cell proliferate. So initially you have one cell, okay guys? Then you start duplicating your cellular content inside of that one cell. What is the why we are duplicating it? Because you want to create more cells, okay? So you duplicate this cellular content, and then all of this duplication happens at G1. Then at S phase you start synthesizing DNA. Then you make more DNA. As you can see here, it's only like 2 single strand, and here there is 2 double strand. Then if there is any mistake, you repair that at the G2 phase. Then the division of the cell occurs during M phase, which is mitosis, in which like the one cell is divided into 2 cells, and then it goes again. So in case of tumor cells, you want this process to occur really quick. How can you make it go really quick? Well, to pass it from G1 to S, for example, you have a regulator, something that prevents you from passing really quick. So you will down-regulate him. You will tell him, calm down. I don't want you to work, so I will be able to go faster. Okay? So if you have inhibition of these police officers, you will be able to go faster. If you will be able to go faster, you will have hyperproliferation. This is cancer. Well, some cancers are smart. They are like, okay, this is what we want. This is exactly what we want. But in the same time, we don't want this hyperproliferation to happen where? Inside of this patient immune system. Because if it occurs in his immune system, his immune system will be able to attack us, the cancer cell. We don't want him to be able to do that. How can we prevent him from doing that? Well, basically we can prevent him from doing that yes, we are hyperproliferating in our cell cycle, but we will go to the immune system cell cycle and we will basically disrupt it. How? Well, make for us many fake police officers that will block all of the phases of the cell cycle in that immune system. So that immune system will be really stupid and will not be able to attack us back. So the tumor cells are basically doing immunosuppression of your immune system by decreasing the function of the cell cycle of the lymphocytes. Okay, I hope it makes sense. If it does not, it's okay. These topics keep repeating themselves, so don't worry about it too much. So the next, let's take a little break, come back, review a little bit of cardio, and call it off for the day. Tomorrow we will be finishing Neoplasia, guys, and start the renal. Okay, I hope you like Neoplasia. It's not a difficult topic. Really interesting. There is a lot to memorize.